This goes onto here. Good idea. Best way to do this is grab this with a hand like this and just sort of wiggle it on. It's not terribly easy to put on, but once it's on there, it sticks, okay? Then I want to support this with this little one there. I want this to be somewhat drifting back this way. If you need to make it higher, unscrew this. I can screw it up a little bit, but that's the proper setting to be right there. This is going to go on the outlet side of my humidifier. This is going to go from my fitting in the back to the inlet side of the humidifier. They come packaged with a 22mm adapter so that you can connect them both like this, all right?
Can I take a picture of this after?
Sure can. Well, you have a colleague who's a video.
Yeah,
This hose with the white lure, guess where it goes?
White.
To the white lure here, okay? That's my pressure sensing line, okay? So that's what's going to sense my mean area pressure and my amplitude, okay? Oh, I didn't take these off. I'm not going to take them all off. That's a mushroom valve.
So this is all separate?
This is all separate. These are
Okay.
3 separate mushroom valves. Doesn't matter which one you put where, they just go on here, here, and here, okay?
Is that in the package with the circuit?
No.
No,
It's a
okay.
separate, 4 separate packages. So that's going
So
to be
the circuit's in a package, then
the mushroom valves in a
mushroom
package,
valves.
these are in a package, and this is in a package.
Okay.
So 4 separate packages. Okay, these are my control tubes. They are color coded. So blue goes to blue, and blue can only go to this mushroom valve here. Okay, so screw it on to my mushroom valve. You're good to go.
Okay.
Green goes to here. And green can only go to here. Screw it on, it goes on like that. Then red goes to red. And this is going to go down, and I'm a bit obsessive about my vent circuits, so I wrap it around like this, just so it looks a little bit nicer. And that goes down to here. That, if you want to take a picture of it now, that, oops, sorry. And then we have our temp probes. Now, if the baby's in a warmer bed, you want to put your temp probe here, and then have it covered over with a adhesive reflective dot that they put on the baby's abdomen.
Mm-hmm.
If your baby's in an isolette, you can eat that as a souvenir. You're going to want to put it here, outside of the isolette. Okay, I don't want my temp probes to be artificially heated. Condensation in your oscillator circuit is going to be a problem. More than it is on conventional ventilation, because these heater wires suck. They don't do very much. Okay, we'll talk a little bit about condensation. And then this is going to go back to here. And we're good to go. Okay. So this is my circuit, how it should be set up.
Small enough.
No, but it's long enough to put it next to the bedside, and we'll talk about that too. Looking at this, it's simply a U-shaped CPAP circuit. Oscillators are nothing more than CPAP. Flow of gas comes from here, into my humidifier, into my circuit, to my baby, then out to my green mushroom valve. My green mushroom valve is what creates the back pressure to create my CPAP, okay? My blue mushroom valve is simply a pop-off, and you set that separately. And my red mushroom valve, you don't set, it sets itself. It's either completely inflated or completely deflated. So I have 3 mushroom valves. So, circuit setup, everybody good with the circuit? U-shape, this is my outlet, okay? So whatever's in the baby is coming out here. We don't worry too much about infection for babies, but every once in a while, just remember, if your baby has a respiratory infection, it's blowing out here. Okay?
We'll put a towel underneath because all the condensation's going to go away.
So if you're good, all the condensation is going to go here. If you're good, it's just Nikki's are miserable. Okay. Oscillator's plugged in, humidifier's plugged in. Here's my main power switch. That turns on everything, okay? Then here's my piston power switch. We haven't talked about that yet, all right? And then I have a blender power switch over here. When Biomed assembled the blender, they lost the O2 sensor. So it doesn't, the O2 analyzer is not working on your blender right now. The blender's working, the O2 analyzer is not. They're looking for it. It may have come separately. It's just not here right now. So to turn on the analyzer, I simply just turn it on here, and it's going to come up with an error code right now. So we're going to ignore that. So we're ready to go. All right. Now, there are 2 tests you're supposed to do. I'm going to tell you to do one of them, because the other test that's on the top of the oscillator is there only if we're at altitude. And it's not terribly high here. We're not we're not mile high. So just do the one on the side. So this is the test here. Okay? It says the patient circulation calibration procedure. So Gina, I'm going to read this off to you. You're going to do this, okay? Mm-hmm. All right. Step 1, insert stopper in patient Y and turn on bias flow gas. Now I want to turn my bias flow gas on to 20 liters per minute. Not 21, not 19, but 20. So get your eyeball right on that 20 line and put it right to 20. We good? Good. Rotate the mean pressure limit and adjust controls right here to max. Cool. Depress and hold the reset button. Press and hold it. And observe the mean airway pressure. And it should be between 39 and 43. If it is, you're done. You can let it go. You're done. If it's not, chances are you have a leak someplace. Or you set your flow meter to your flow to the wrong flow. Don't get frustrated and go, this is going to be forever. Make sure this is at 20. Make sure that all your mushroom valves are popped in. Sometimes that green stopper isn't a terribly good stoppage, so maybe take your sterile respiratory therapist thumb and hold it over there. Bypass the humidifier dome. Sometimes they leak, especially the water feed system. So the way that I have it set up like this, we passed fine, not a problem at all. Don't, and you're going to see this on the videos, don't put a screwdriver in here and adjust this screwdriver, this screw here. That's just for Biomed. You shouldn't need to do it, okay? So, our vent checked out fine, we're good to go. If you wanted to, I could just unstop this and we'll go there, okay? All right, I'm going to turn this off for a little bit, because let's talk about settings. Okay. We comfortable with the circuit? Okay, good. Let's talk about the settings. I contend that the oscillator is an easier ventilator to use than conventional ventilation is, because there's only 4 settings. Even better, and that's in here too. Trust me, I try to make this as easy as possible for you guys. It's actually in there when we go into settings and controls. It talks about the 4 settings. Okay. Even better, there's only 2 settings for oxygenation and 2 settings for ventilation. So if your baby has oxygenation problems, you're going to play with 2 settings. If your baby has ventilation problems, you're going to play with 2 settings, and that's it. The 2 settings for oxygenation are on the left-hand side of the ventilator. And they're FiO2 and mean airway pressure. Now, let's talk about FiO2 first, because that's the easier one. Who's my NICU special? Who's my NICU expert up here? Who feels comfortable up here in the NICU? They always dime each other out. No one ever raises their hand whenever they want to teach graphics. Who knows graphics? I ain't gonna say that. What's a safe FiO2 for a baby? Very good. 21% is the only safe FiO2 for a baby. That being said, I want to get my FiO2 down as quickly as possible as soon as I put my baby onto the oscillator, okay? But when you first put your baby on the oscillator, and I'll explain why, you're going to want to move your FiO2 probably 10% above where they were on conventional, because you're going to deflate their lungs, you're going to de-regroup their lungs are going to be completely deflated for a little bit. So I want to give them a little bit more oxygen to put them on. Okay. Mean airway pressure. I try to relate the oscillator to your conventional vents. Okay. What setting on your servo or on your Vyaire is equivalent to the mean airway pressure setting on my oscillator, and it's not mean airway pressure. So if you're looking to follow along, I'm on slide 24 in your hymnal. Exactly. This is nothing more than my CPAP, my PEEP, my continuous distending pressure. And if you look on the, don't look, but if you look on the front here, you'll see little labels, and these are labels that I've seen other hospitals put on their oscillators. I love oscillators that have labels on them. Because when you set this up, this should not be a test, this should be a cookbook. So if you have someone who has a label maker, make your little labels to tell you what this is. And one label I love to have is, call this my continuous distending pressure. Because that's what it is, it's not your mean airway pressure. Where should I set this? I haven't told you how to set it yet, but where should I set this? The neonatologist has asked you to put this baby on the oscillator, but they have no clue where to start this baby off at. Where is it? Anybody know where I should set this, what my mean airway pressure at? Now, 2 above the baby's mean airway pressure that they were on conventional. Cookbook. Well, Tom, what if the baby was never on conventional ventilation? Where should I set it then? Stroke your chin 3 times. If you have glasses, take them off and bite the earpiece and say 12. Because that's a good guess. It's where most of us start. It's a swag, strategic, wild-ass guess. You have no clue if that 12 is good, but that's where you want to start the baby, okay? So your mean airway pressure is going to start at 2 centimeters above the mean on conventional, or at 12. Good place to start, all right? I haven't shown you how to set it up yet, but we'll talk about that, all right? Now, how do I know that 12 is what's right for that baby? What diagnostic test do you think should be taken? And you're on the proper page, and I'll give you a hint. Every question I ask you, the answer is on the slide in front of you. You're on the page too. What diagnostic test should be taken to know if that mean airway pressure is correct for that baby? Chest x-ray. Not a pulse ox, not a blood gas, a chest x-ray. Your baby's pulse ox will tell you you're in the proper neighborhood, but won't tell you where you need to be. Chest x-ray is what you need to take. You need to wait at least 30 minutes to an hour before you get that chest x-ray. Now here's why. Here's why the oscillator is so problematic sometimes. Conventional ventilation works by convection. It takes some flow, shoves it in your baby's lungs, pops those lungs open, and it happens almost immediately, right? The oscillator does not work by convection. The oscillator works by diffusion, okay? It slowly puts that gas into your baby's lungs, okay? So here's the analogy I'll give you. Imagine this morning you spilled some orange juice on your countertop, okay? And that orange juice represents airflow into your baby's lungs. Well, you go and grab a paper towel, okay? And that paper towel represents your baby's lungs. If you're a conventional ventilator, you smack that paper towel down on top of that orange juice, the orange juice immediately goes up into the paper towel, but it's very poorly distributed. Some parts of my paper towel have way too much orange juice and they rip. Some parts of my paper towel have no orange juice and they're perfectly dry, but it happened immediately. Okay? That's conventional convection ventilation. You're the oscillator now. Same orange juice, same airflow. But you're going to take that paper towel and lay it to the side of the orange juice and let the orange juice creep in to the paper towel. You have time to go upstairs, take a shower, get dressed, come back down, and then you'll see that the orange juice has crept into the paper towel. That's the oscillator. So the oscillator works by creepy orange juice. All right, just keep that thought in mind. That's how the oscillator works. That's why it's incumbent upon you guys to put your baby on sooner rather than later. This is why the oscillator fails in a lot of NICUs, because we wait till the baby's circling the drain. Well, if I put a baby who's circling the drain on the oscillator, then make them wait a half hour to even get that gas into the lungs, it's not going to work. And then it's like, see, I told you respiratory sucks, put them back on conventional. And it makes your experience in the NICU even more intimidating than it can be. Put your babies on sooner rather than later, because creepy orange juice. Okay. Okay. So I've put my baby on a main airway pressure of 12, and I've got my chest X-ray. There are 3 landmarks you want to look for on that chest X-ray. Can anybody tell me what they are?
It's right here. Lung inflation to the 8th and 9th.
Right, so I want to see 8 to 9 ribs. It's easier to look at the ribs that attach to the spine and count them there. So think of baby back ribs. So think of Chili's baby back ribs, right? So I want to see 8 to 9 baby back ribs. What else do I want to see?
Round diaphragm.
Rounded diaphragm. So think of McDonald's arches, okay? Rounded diaphragms. And the last one is clear or clearing lung fields. So the 3 things you want to see on this chest X-ray, and you should be looking at it, are 8 to 9 ribs, clear to clearing lung fields, and rounded diaphragms. If I see only 5 and 6 ribs and a schmutzy, dirty lung field, is this too high or too low?
Low.
Too low, right. How much should I move it up by? 2 to 3. Be aggressive moving it up. Because until my lungs are popped open, nothing's going to work very well. Now, what if I see flattened diaphragms and widespread ribs? Is that too high or too low? Too high, what should I move it down by? 1. So be careful moving it down. So be aggressive moving it up, be conservative moving it down. Why do I want to be conservative? Because baby's lungs don't collapse linearly. Baby's lungs collapse all of a sudden. And I don't want to go zooming past that point. Once I get this set and confirmed by chest X-ray, daily chest X-rays are good. And that's all you're going to need. Okay? You should be looking at them. Make sure that my baby's lungs, I still have rounded diaphragms. Make sure that my baby's lungs are still 8 to 9 ribs that are fairly clear. That's going to become very important as your baby gets better. And we'll talk about that a little bit later, one of the problems with the oscillator. But as your baby gets better, those X-rays are going to become very important. Okay. So what are my 2 oxygenation settings? What are my 2 oxygenation settings? We just talked about
Mean and FiO2.
Mean and FiO2. FiO2, where should I start my FiO2 at?
A little bit. 10.
10 above what they're unconventional, and then quickly bring it down. As you get your chest, as you get your pulse, Jesus. As you get your blood gases back and your PaO2s are high, the first thing you want to move down is your FiO2. You don't want to change your mean, well, that's your PEEP. I want to keep my lungs open. I want to bring my FiO2 down. What's my other oxygenation setting besides FiO2? Mean.
Airway pressure.
Where do I set that?
2 above what they were, or 12.
There you go. And how do I know that my mean is correct? What diagnostic test?
Chest X-ray.
Now,
After half an hour to an hour.
be prepared. When you first put your baby on the oscillator, it's going to look like you made a mistake. The baby's going to look awful. Why do they look awful? Because their lungs are collapsed. And I have to creep that gas into my baby's lungs. Since this is new to everybody here, be the experts. Prepare everybody. Hey guys, just to let you know, first couple minutes this baby's on the oscillator is going to look like they're dead. Okay? They're going to be saturations down in the 60s. They're going to look awful. Keep an eye on the baby sat. After about 5 minutes, you should start seeing it rebound. Why? Because I've started to open up some alveoli, right? If I don't see it getting better in the first 5 to 10 minutes, start bumping up on this before I even get my chest X-ray. Okay? In your little sheet there on the page, right, where was it? No, good. I took it out. There's some hospitals that just keep on going up and up and up on the mean airway pressure until they get so high and they collapse the capillaries and bump it back down. It comes down to the chest X-ray anyway. Just do it the proper way. Okay? But just prepare everybody before you put them on. Your baby's going to look bad when you first put them on the oscillator. Okay? It's okay. I have collapsed lungs that I have to slowly creep back open. All right, good. I'm going to turn this bad boy on so we can get the other settings set. So, what do I do with this? How do I turn the oscillator on? Okay. Okay. So, I have this flow set here at 12, okay? Or probably at 20. I'm going to probably want to move it down to about 10 to 12 liters. So I'm going to move this down. And the reason I want to move it down is Too much flow can increase my baby's work of breathing. Too much flow can also hamper the negative suck I get with my piston. The problem is I don't know how much too much is, okay? I'm telling you, we recommend 8 to 15 for premature babies. 10's a good place to start, and I'll tell you how you can find out, okay? So I'm gonna set that. So I have my flow, and I have my green mushroom valve. How come I have no pressure?
It's open to baby.
It's not open.
It's on.
The reason it's closed, and you're going to see this all the time when you have your baby on and you take your baby off. Whenever you take your baby off, like we just did, the red mushroom valve deflates, opening up just a huge hole in the entire circuit. In order to repressurize the circuit and to restart my oscillator, my piston, I have to reinflate my red mushroom valve. You'll notice this little light is on. It says mean air pressure is less than 20% of set max pull. What that means to you guys is the pressure in the circuit is less than 20% of this number here. Do you know what number is that?
46.
Oh, jeez. Okay, it was on me 46.
Not supposed to be there.
Well, let's make it a nine. Let's make it a
41.
round. Is that 41?
That's 41.
Let's make it 40.
40.
Okay. I set my high peak pressure alarm, and it's just an alarm. It's not a pop-off, it's just an alarm. I've set my high peak pressure alarm to 40. What's 20% of 40? 8. If what this light is telling me is the pressure in the circuit has dropped below 8 centimeters. When that happens, it deflates the red mushroom valve and says, okay, I'm going to lose all my pressure. In order to start things back up, I've just reattached my baby. I'm just starting the ventilator up, whatever I'm doing. I have to reinflate the red mushroom valve. You notice there's a little line that goes from this light over to this button here. That's not just there for aesthetics. It's there to say, hey, this is the button you want to push. Press and hold this button until I reach 8 centimeters. Then all of a sudden I now have my mean air pressure there. I've reinflated my mushroom valve. If I had my piston turned on, my piston would be going also, okay? So anytime you disconnect your baby, or before you put your baby on, in order to get the system up and running, you have to reinflate the red mushroom valve, and it's done with this button right here, okay? Okay. So I'm going to set this up for my baby. I'm going to use my green stopper, because I'm at the bedside, okay? So what do I do to get this started again? I just disconnected my circuit. What do I do to get? Which one? Go ahead. Press and hold it. Now you have to press and hold it. Sometimes it may be just for a second. Sometimes it may be 1 to 2 seconds because it depends on how high this is set. This is set at 20. I only have to go up to 4 centimeters. This is set at 40. I have to go up to 8. And it's set at 50. I have to go up to 10. Okay. All right. Hey, John?
Yes.
Oh, that was a good guess. You're the neonatologist today, okay? Give me an order for your mean airway pressure and tell me why you gave it that way. Oh, don't overthink this. Just give me a number. Just let one fall out of your face there. 14. And why did you say 14? Because your baby's conventional mean was 12. That's why. So you said 2 above that, 14. If the baby had never been on conventional ventilation, 12 is where you want to start. Okay, so what creates this mean airway pressure? Well, I have my flow from my bias flow meter here, going out to my baby and then back through here. It's the size of this mushroom valve that creates my mean airway pressure. The bigger that mushroom valve, the higher my mean airway pressure. The smaller that mushroom valve, the lower my mean airway pressure. What controls the size of this mushroom valve? What button or what knob on here do you think controls that? The green knob. This is just another flow meter, okay? So all I want to do is I want to adjust this knob until this reads 12. So you have a flow meter here. I have a flow meter here. You just can't see it. So I want to adjust this until that reads close to 12. 12.1 is fine. Okay. This inflates that. Okay. turn this counterclock, we'll turn this clockwise.
I get it now. It's green, green, blue, blue.
Exactly, you got ahead of me.
I'm sorry.
We haven't said this one yet. So this, I'm telling you, it's a simple event. It's color coded. So the green knob is the flow meter that sets the size of the green mushroom valve. The green mushroom valve is what creates the back pressure, which then creates your mean area pressure over here. Okay? Now, if this mean area pressure was too low, if this bias flow was too low, what you would see is your mean area pressure would constantly dip every time your baby took a breath in. So I'd want to bump it up. If this bias flow was too high, you really couldn't tell. But what we recommend to you guys is, see this little pointer on here on the green knob? That little pointer, that's in slide 29 of your hymnal. That little pointer should be between 10 o'clock and 2 o'clock on the ventilator face. Okay, see how it is between those two little lines? Knowing that, with the way I have this set up right now with no baby attached, so I'm going to attach a baby so it's a little bit easier to see. Oh crap, I disconnected. What do I have to do? There you go. You're good.
So just wait for the beeping to stop, and then you can let go?
Yeah, no, actually, you just, if you want to get a little bit, you can stop, you can let go, that'd be fine.
Okay.
You'll know it better because you'll hear the piston start. We haven't talked about that yet.
Yeah.
Knowing what you know about where this pointer should be, is my bias flow too high or too low for this baby? Remember I said that pointer should be between 10 o'clock and 2 o'clock. My pointer is really about 3 o'clock, right? So my bias flow is probably too high.
Oh.
Too high. My mushroom, too low.
Right,
Too low.
because if you
Almighty.
decrease this, then your pressure's going to go down.
Right, so I need to
you
bump this up a little bit, okay? So bump that up, turn this back. I'm sorry, that was confusing. Forgive me. Good. If my pointer is too far clockwise, it means your bias flow is probably too low. Your mushroom valve is too big, you probably need to bump your bias flow up a little bit, make your mushroom valve a little bit smaller. If your pointer is too far counterclockwise, it means your mushroom valve is too small, your bias flow is too high, move your bias flow down, make your mushroom valve a little bit bigger. So my pointer is right about where it should be right now. I'm around between 10 o'clock and 2 o'clock, okay? Don't raise your hand, but yes, just go ahead and plug it in.
So, say I was setting this up on a baby, they want whatever pressure, would I move this before moving this?
So I would just
that
set this at an
my
arbitrary
point is-
number. I would just put this into an arbitrary setting. If you want to put it at 12, put it at 12. If you want to put it at 10, just don't leave it at 20.
Okay,
And then from that point on, you're almost always going to adjust everything based on the doing.
okay.
Yeah. You shouldn't have to change your bias flow at all. The only time you may want to change your bias flow is this. If I have a baby whose CO2s just won't come down, and I've maximized my ventilation, I still can get my CO2s down, perhaps this bias flow is too low, and it's not flushing out the CO2 that the piston sucked out with the previous breath. So by bumping this up by a liter or two, you may flush out that CO2 and drop your baby's pH CO2. Remember, the piston pushes gas in, but it also sucks gas back out. And if I don't flush that gas out, that CO2 out with my bias flow, my baby may be rebreathing it. So it's just one of those things that you can look like a magician, or it may not do anything. So that's the only other time you may want to adjust
Okay.
this.
So
okay?
I'm really just worrying about the knob.
Green knob. Yeah, good. Okay. Let's set this now. This is my limit knob, okay? So remember I said this is my high peak pressure alarm, but it doesn't pop off. My pop off is a separate setting. It's my blue knob here. And basically all you're doing, guys, is you're setting your blue mushroom valve to be slightly bigger than your green mushroom valve. That way if the pressure ever goes up in my circuit, it will pop off there too. So what you want to do is set this to max, then slowly turn this counterclockwise until I see it affect my mean air pressure over there. Up. It did it. Stop, turn it a quarter of a turn this way, and you're done. I have no idea where it's set. I don't care where it's set. It's just there. It will pop off at some point. Be careful. Every time you make a change in your mean, turn this back up to max. I've run into too many hospitals where they're like, Tom, we're trying to bump up my baby's map and it won't go past a certain number. It's because it's hitting up against this limit here, and I start feeling the gas coming out of here instead. So get this out of the way when you make your changes by turning it to max and then turn it back down to whatever. I go to some hospitals, they just leave it at max all the time too. It's rare that something happens to your mean air pressure to cause it to pop off, but it's a simple matter. Just turn it back down, see where it affects, and a quarter turn to the clockwise will take it away. Good with mean? That's my mean. How do I know my mean's correct? How do I know this is what the baby needs?
Chest X-ray.
Chest X-ray. How long should I wait to get that chest X-ray?
30 minutes to an hour.
Half an hour to an hour. What are my 3 landmarks?
The ribs,
Yes, ribs. I want to make sure my baby's a vertebrae, right? How many ribs?
8 and 9.
8 to 9. Okay. What else?
The diaphragm,
Diaphragm. What's my diaphragm there? What about my diaphragm?
make sure it's not flattened or flat.
Rounded. The claustrophrenic angle. Just drop that every once in a while. Oh, no, there's a claustrophrenic angle. Make sure the baby knows. What else? Clear to clearing lung fields. I don't want 8 to 9 ribs, but a dirty lung field. Okay, good. If I see flattened diaphragms, this is what? Too high or too low?
Too high.
Too hot.
Too high. What am I going to move it down by?
1.
If I see 6 ribs and a dirty lung field, this is too high or too low?
You need to go up.
You go by how much?
1, 2.
Aggressive going up, conservative coming down. That's your oxygenation, guys. That's it. Left-hand side of the ventilator. I know that your knob's over here, but that's my CPAP, that's my continuous ascending pressure, that's my FiO2. Okay? And that's all you have to worry about for your baby with O2 problems. Other settings won't do a thing for you. Okay? That's just CO2 settings. So my O2 settings are mean airway pressure and FiO2. Good? And my FiO2 is basically cookbook, 10 above and then turn it down. And my mean airway pressure is basically cookbook, 2 above the conventional, and then chest X-ray. So simple, simple. All right. My 2 ventilation settings are the middle of my ventilator. I have my power knob and my frequency knob. Those are my 2 settings. Okay? Here's the analogy I use for ventilation. And it may be kind of childish, but it seems to work. Every time the oscillator oscillates, it creates an empty railroad coal car. Okay? And every coal car shoves the one in front of it down your baby's lungs, picks up some CO2, and comes back out. And you control 2 functions of those coal cars. How deeply they're shoved into your baby's lungs, that's the power knob, that's the shove knob. And how big those coal cars are, that's my frequency knob. Doesn't make sense to you right now, it will. So I want to make sure that not only do I shove my coal cars down deep in my baby's lungs, but that they're properly sized to pick up enough CO2. It does me no good to have properly sized coal cars and not shove them where they belong, nor does it do me any good to shove coal cars that are too small where they belong either. So I need to have both those factors there. Okay. None of you have worked with the oscillator before, correct? Have you?
I have.
Okay. So what I'm going to teach you is the right way to do this. It's not the way that you probably learned, okay? The settings. Most hospitals do it incorrectly. The physician says to respiratory, put that baby on an amplitude of something, of 20, 18. They have no clue. It would be like in your adult world having a physician say, put that patient on a plateau pressure of 17. Yeah, you could do it, but how'd you know? So you're going to walk over and you're going to go over to this knob here and adjust this power knob. There's a lock on this knob to lock it in place, unlock it, you can move it around. There's a number up in here, and then there's numbers on the scale around here. You would adjust that power knob to achieve that amplitude the doctor gave you. That's the wrong way to do it. The correct way to do it, and this is what I told the docs here this morning, is to tell respiratory, go tell me what power this baby needs to shove those, no, I'm not going to say this part, to shove those coal cars where they belong. So what you're going to do is, you're going to turn the piston on, and you're going to come over to here and adjust this knob. Now usually you start with a number 2 in here, and you're going to adjust this knob here until you see what's called optimal chest wiggle on your baby. Just like that. Optimal chest wiggle is a wiggle that you can see visibly from the baby's clavicles down to their umbilicus, or umbilicus, or belly button, whatever you want to call it. Okay? If it doesn't get down to your umbilicus, you need to bump up your power. If it's past your umbilicus, you can move your power back. We don't think there's anything that's such as too much power until you've shaken your baby, until your baby wiggles so much they fall off the bed. It probably isn't a thing. But I want to adjust this until I achieve what's called optimal chest wiggle. I'm then going to note the number in this window and the number at the top of the scale and go back to the doc and say, Doc, we're at 2.55, that's the power. Good, I'm going to write that order. And I'm going to write that order for 2.55. Oh, and by the way, Doc, it's giving me an amplitude of 37 centimeters. Okay, good, I'll keep that in mind. The vast majority of NICUs, and this is 35 and 36, the vast majority of NICUs do it incorrectly, and they set the oscillator based on amplitude. Amplitude is not a setting to be achieved. There is no amplitude knob on this ventilator. There's only a power knob. You guys are in the very unique state that you're starting off the oscillator brand spanking new. You're the first new oscillator user I've had in 3 years. So you got a chance to do this the right way. So I told the physicians to have you tell them what power the baby needs. You'll then write that, you'll then check the baby to see their optimal chest wiggle, and then you're going to write that, they'll write the order for that power, and they'll note the amplitude. Now, guarantee you're going to get some physicians in here that are going to tell you, put that baby on an amplitude of whatever. You're going to nod your head and say, yep, whatever you want. You're still going to come over here, adjust this baby's power knob, and they're going to wiggle like that, okay? They won't let me bring a real baby in, so you're going to have to pretend that's a baby. They're going to wiggle like that. You're going to adjust your power. I don't care what the doc told you in terms of amplitude. You're going to adjust your power until you achieve optimal chest wiggle. Then note what the amplitude is. Go back to the doc and say, Doc, I know you told me 20, but I'm getting optimal chest wiggle at 24. Okay, all right. Physicians understand optimal chest wiggle. They just don't know how to get to it. Okay? So basically, you're going to adjust this shove until you achieve optimal chest wiggle. Okay? So what's this then? What's amplitude, or delta P? It has 2 names, amplitude or delta P. What is that? If it's so important that docs order it by it, what is it? What is it? What do you think it is?
It's the pushback.
It's the pushback by the baby's lungs, by the baby's ET tube, and by the circuit against that shove. And here's the best analogy I can give you for it. You guys all understand waves down the seashore, right? What causes a wave in the ocean? Well, I have a power, the wind, blowing a fluid, the seawater, up against an obstruction, the seashore, okay? So if I have a power blowing that fluid up against a very high compliant, low resistance seashore, I get very small waves. The height of those waves is very short. The amplitude of that wave is very short. All amplitude means is height of a wave. Okay, I have the same wind, the same power, blowing the same fluid, the seawater, but now I've dumped a load of boulders on the seashore. High resistant, low compliance, big waves, big amplitude. That concept for the waves down the seashore holds true to the oscillator. Power pushing a fluid, the air inside here, up against the seashore, the baby's lungs, the baby's ET tube, and the circuit. So all this is showing you the pushback by the baby against this power. Inevitably, during the course of your day, this number is going to change. So let's say this number went from 37, which is fairly high. You wouldn't normally see a 37. But it went from 37 up to 40. Okay? Nurse is going to call you, respiratory, get up here right away, the amplitude's wrong. Is that increase in amplitude a good sign or a bad sign?
A good sign.
You say it's good. What do you say? Bad?
It's bad.
Dad.
Either you're very brave,
You're increasing the resistance.
so I'm increasing the pushback. It's a bad sign. It's a bad sign. And how would you know it's a bad sign besides me telling you?
The baby looks bad. I don't.
Why? And what looks bad about the baby?
There's less vibration.
Less wiggle. You can answer chest wiggle to every question I answer you now. Ask me now, you're going to be right. Less wiggle. Right. So the nurse says, respiratory, get up here right away. It's up to 40. You're going to walk the baby to the side. Yeah, look, my wiggle's less than it should be. That's a bad thing. When you have a baby on the oscillator, the very first thing you should see when you go to their bedside is a wiggle. The very last thing you should see before you leave is their wiggle. How do I fix this? What you don't want to do is what we call chasing amplitude. What I don't want to do is simply turn this knob down so it goes back down to 37. The baby's telling you, hey, I'm pushing back harder against that power. If you want me to get ventilated and restore optimal chest wiggle, you've got to give me something stronger. If you said, oh, let me just give you something weaker to go back to that arbitrary number, you've done completely the opposite. How do I fix suboptimal chest wiggle? How do I fix an increase in amplitude?
Increased power.
Suction. Reposition the ET tube. Make sure the ET tube's not kinked. Dump the water out of here. Almost always it's going to be something mechanical. Fix the mechanical problem. If I fix all the mechanical problems, okay? And come in. Or go. If I fix all the mechanical problems and my amplitude is still less than it should be, then I'm going to bump up my power until I re-achieve.
Hi, how are you? My name is Joanne Stewart, I'm the nurse manager.
Hi, Joanne.
I know you're in servicing the respiratory unit. How much longer is this?
Probably about another 15.
Okay, because really they shouldn't be here.
Well,
I talked to Kelly, she didn't set that up.
no, she didn't, but unfortunately the residents popped in earlier.
Okay, they should not be in my unit.
Oh, we were told by Dr.
Because they are covering the whole hospital. This is a NICU,
Okay, so, well, we were told by Dr. Peralta this is where he wanted to do all the training.
not for my nurses, yes, not for,
Okay.
but you got 15 minutes. and
Okay.
everything. Yeah, I hope you all have, you don't have an N95, and you're not even wearing your mask properly.
Oh, she's a trauma. So try to fix the problem. If you can't fix the problem, bump the power up to achieve new chest wiggle. And then note what the new amplitude is. And that's the new amplitude. Just this is there. Think of it as a little bit like plateau pressure on conventional ventilation. It just is. If your plateau pressure goes from 15 to 17, you're not going to make changes to put your plateau pressure back down. You're saying, oh, my plateau pressure went up. Okay, I'm going to put it. What if my plateau pressure goes down? And it went from 37 down to 35. Good sign or bad sign? Go ahead, say it. Say it.
Yep, I said,
It's a good sign. Usually it's a good sign. Less pushback. However, this is a weird pressure. We're not used to dealing with delta pressures in respiratory. Okay? We're used to be dealing with finite points of pressure, right? Pips and peaks and plateaus. This is a delta. Between my two hands is my delta P, is my amplitude. The same things that can make this part go up and make my delta P bigger can on occasion make this part go up and make my delta P smaller. So if you see a decrease in your amplitude, how do you know it's a good sign or a bad sign?
we're gonna be
chest wiggle, chest wiggle, chest wiggle, chest wiggle. If this has gone down and my chest wiggle is less than optimal, do the exact same thing you would have done if it had gone up. Suction, reposition the tube, make sure that, put some tension on it, clear the circuit. If my pressure has gone down and my wiggle is still optimal, or maybe even super optimal, great, baby's doing better. Good sign, as long as you're getting more compliant, yay, that's what we want to do, okay? So that's power, that's amplitude. Set the power to achieve optimal chest wiggle. Note the amplitude as just an indication of the pushback. Make sure you document someplace in your notes, because I doubt right now your ventilator flow sheet has any place to document that you checked wiggle. Make sure you document it in your text notes that you baby had optimal chest wiggle, or whatever you want to call it. Because if something happens to that baby, you're called in the court and they say respiratory, how did you know that oscillator was working? I checked the chest wiggle. Yeah, where did you document that? If you didn't document it, you know that it doesn't exist, it wasn't done. So make sure you document it someplace. And as you guys move forward, you want to come up with your own flow sheet for the oscillator. You want to include chest wiggle optimal and have it check as well. Okay. Okay. So that's setting number one. And that's purely subjective on you guys. You set it based upon the baby's chest wiggle, and then it just is. I just note the number. Setting number two is this one, my frequency. This sets how often that piston moves back and forth. You can look in my diaphragm right here. You see it shaking back and forth very, very quickly. It's actually shaking back and forth 900 times a minute. Multiply this number by 60. That's how many times that piston is moving back and forth. That's the last time I want you guys to think of this as a frequency. Because it doesn't matter its frequency. Because whether it's 900 breaths a minute or 840 breaths a minute, it's still a crap load of breaths. But what I want you to remember is this number sets tidal volume. It sets the size of that coal car. And here's what you have to remember. The higher this number, the smaller my tidal volume. All right, and that has to do with how much time my piston can spend moving forward into my circuit. The less time it can spend moving forward to my circuit, the smaller my tidal volume. So our recommendation is babies under a kilogram, you should start their frequency at 15, which is the highest number you can go to, which is the smallest tidal volume you can deliver. Okay? If you wanted to increase your tidal volume, I would move down. Traditionally, the next stop seems to be 12. We don't know why. You can stop at 13 if you want to. You can stop at 14 if you want to. But 12 seems to be the traditional stop. Lower the rates, higher the volume. The last stop you want to go to is 10. We still don't recommend that you go much below 10 for your babies, except babies who may be 2 to 3 months, 2 to 3 years old. Okay. So 10 seems to be the last stop. That's the lowest frequency you should be playing with. That's the biggest tidal line you'll be playing with. So respiratory, I have an 850 gram baby who was just born. I want you to give me the oscillator. I want you to give me the ventilatory settings. I'm the therapist. I want you five to be the neonatologist. Tell me what you want to do ventilator settings.
You want to start with a mean airway pressure 12?
Oh no, just ventilator settings. Just ventilation settings. Yeah.
Oh.
So what do you want me to do first? Well, you want me to set a power, don't you? I have to set that wiggle. So what do you want? What do you want from me?
Give me good chest wiggle.
Right. So you just basically want me to tell you what the power is to achieve that chest wiggle. So Doc, I'm at 2.35. Okay, good. I'll write that power down. It's just 2.35. So it's basically the volume knob in your radio. Okay. Okay, good. So I've set that. You also want me to tell you what the amplitude is. And Doc, I'm getting an amplitude of 34. Okay, good. Where do you want me to set this? It's an 850 grammer.
15.
15. Why 15?
He's under.
Giving more weight, less volume.
Less volume. Don't even think about rate. Just less volume. Very good. And that's my settings. You have 2 ventilation settings you can play with. Okay? I have my power and I have my frequency. This is very conservative. This is very aggressive. So most docs will play with the power. And this is what most docs will do. They'll get a blood gas back and they'll say the baby's CO2 was elevated. They're going to go to respiratory. Respiratory, can you go up by 2 centimeters on this to 34 to 36? That's their comfort zone. That's what they'll probably do. Okay? That's fine. You know what they basically ask you to do. Can you shove that cold bar slightly deeper into my baby? Can you make them wiggle slightly better? So I'm going to simply turn my power knob, adjust it up, check my chest wiggle. Oh, good. It's still good. Okay, doc, I did what you wanted to do. Okay? Don't be afraid of this number. Top right hand, that's what we're at. So this one. This number gets eaten by your baby's ET tube to a huge extent. So much so that if a baby has a 2.5 ET tube in, which is what most your babies will have here, only 10% of this number gets down to the end of the baby's ET tube. So although this is reading 36 centimeters of pressure, which, oh, that sounds like a lot of pressure, it's only 3.6 at the end of my baby's ET tube, which is very little pressure. Even better, of that 3.6, only half of it goes above on the inspiratory side, so 1.8 above, and then on the expiratory side, 1.8 below my mean air pressure. So mean air pressure is 13, right? This is 36. So in my baby, it means it's going up to 14.9 on the inspiratory side of my lungs and going down to 11.3 on the expiratory side. Actually have a negative pressure sucking CO2 out. Don't be afraid of amplitude. It gets greatly attenuated by the baby's ET tube. I've had amplitudes on pediatric kids up to hundreds. Just it is what it is, okay? We offer you no guidance in terms of amplitude. The only thing that we can tell you is an anecdotal thing that your amplitude here shouldn't be more than 3 times your mean air pressure here. So let's say this was 40, okay? And this is only 13. That's more than 3 times your mean air pressure, right? So it's basically telling you that your mean air pressure is probably too low. I have a bunch of collapsed alveoli and that railroad cold bar is hitting them and bouncing right back out. Bump this up, you'll probably see this come down. Okay, so what are my 2 ventilation settings? This is when you respond to it. What are my 2 ventilation settings?
Frequency and amplitude.
Frequency, stop with frequency.
Oh, sorry.
Frequency really sets your watts. Tidal volume. And the secret to my frequency is the higher the frequency, the watt the tidal volume. And you'll notice one of the little labels I like to put on here is high frequency equals low tidal volume. Right. I have an 850 gram baby. Where's a good place to start my frequency? 15 watt.
Under 1,000.
And there's the least amount of tidal volume. What's the lowest frequency I should ever go to? 10. You probably don't want to go below 10. Some docs do, and my feeling is they're trying to make this a conventional ventilator, not have enough people. Okay?
So we're really only doing frequency between 10 and 15?
No, 10 and 15, yep.
10 and 15.
And don't get locked into saying like I only do 10, 12, and 10,
Right.
15, 10, and 12. You can do 13. I probably wouldn't fart around with 13.5s. You're going to find that very rarely does the doc change this anyway, because it's very aggressive, and neonatologists are very afraid of blowing off too much CO2, because too much CO2 causes alkalosis, which causes brain bleed. So they're afraid of that. So unless your baby is really, really acidotic or really, really alkalotic, rarely are you going to see a change in this, except for one cause, and we'll talk about that. Okay? My other setting is my power. How do I know that my power is correct? Chest wiggle or convulsions, one or the other. Chest wiggle. Optimal chest wiggle is from where to where?
From the top over belly button.
To the belly button. Anybody know what it is for PEDS patients? Clavicles to hips. Adults, clavicles to mid-thigh. Makes sense. The bigger the patient, the harder I have to shove those bars in there, the more wiggle you have. You don't realize this, but you are now experts in adult ventilation oscillation because the concepts are exactly the same. If I had an adult on this, and I couldn't, but if I had an adult on this, what would I set this? When I set it high or set it low?
No.
No, because bigger tidal volume. This is still the same. This is still power is power. This is still the same. Peep is peep. That's still the same F5 as F5. The only difference is when adults, I use lower tidal volumes. Good. Ignore this number. I don't care about this number. It stays at 33%. It never changes. But I have a hard question for you. If I turn this up to 50%, it will have an effect on your tidal volume. Will it make your tidal volume higher or lower? Who said higher? Why'd you say that? You're right. Why'd you say that?
You just increase the eye time.
Very good. I did increase my eye time, which why does that increase my tidal volume?
You're giving more time for the patient to anything else.
No, but you're close. I'm giving more time for my piston to push the gas in front of it. Bigger, more time, bigger tidal volume. However, what have I decreased? My E time. And remember, there's a negative suck out of CO2 on the expiratory cycle, so this may not do anything. It may have increased my inspiratory tidal volume, but it may have decreased my expiratory suck out, so it may be a wash. That's why no one ever plays around with it. It just sort of stays at 33%. You know, when you get a microwave from the store and it has 12 o'clock on the clock setting there, you could probably put a 33 on this and no one would ever know that it's there.
We don't really touch it.
Nope, it just stays at 33. So, recap of settings, because we're basically in the home stretch now. What are my, I have 4 settings. What are my 2 oxygenation settings? Mean air pressure, which is really my what? What's my mean air pressure? Really, what is it, Mike? CPAP peak. Where should I set it? What do I set it to? No, not how. What
Two
number?
above whatever they were on already.
What? What were they on? What number?
What do you mean?
What number are you saying to above?
2 above whatever they were on before.
What was that? Whatever is it is.
12.
No. You just said what number is that? Is that my PEEP? Is that my PIP? Is that my
I'm guessing peak. I don't know.
mean air pressure? Mean. That's the reason I asked you. Not their PEEP, not their
Okay.
PIP. Their mean. Okay. If they never run conventional, where should you set it? Okay. How do I know it's correct? Test X-ray. How long should I wait for the test X-ray?
30 to 1.
What's my other oxygenation setting? Where should I set that?
10 above.
10 above, and then quickly bring it down. Very good. What are my 2 ventilation settings?
The power. The frequency.
How do I know where I should set my power?
Chest wiggle.
Chest wiggle. Optimal chest wiggle is from where to where? Very good. Where should I set my power? Power actually sets what?
Amplitude. Amplitude?
I didn't hear you.
The amplitude.
No, I'm sorry. Frequency actually sets what? Tidal volume. Where should I set this? Higher the frequency, the what my tidal volume. So the smaller my baby, the what my frequency. Yeah. What is amplitude? Well, what it is
Whatever the
not is something to be achieved or adjusted to. What is amplitude?
Pushback.
It's the pushback against the power. If it rises, bad sign, fix the problem or adjust the power. If it drops, usually a good sign, but it could be a bad sign, fix the problem, adjust the power to achieve optimal adjustment. Good. Okay. Good? Good. All right. Alarms are over here. High peak, low peak, those are just alarms, they're just audible alarms. You guys will decide how to set them. Most of my hospitals will set them 5 centimeters above and 5 centimeters below whatever their mean air pressure happens to be. Okay? Those are the only 2 alarms you have. Okay? Okay? So that's what, 30 now? Okay, good. All right. Alarms down here. Source gas flow means there's not enough gas coming from the wall into the back of the ventilator. You won't see that most of the time. However, I have a very old blender. Sometimes the filters inside the blender can get clogged, and it says there's not enough gas coming out of it. If you can still get enough flow coming out of here, don't worry about the oscillator, go ahead and use it, you're good. But tag the blender, it needs to get cleaned. Battery low is that 9-volt battery in the back of the ventilator that says it needs to be replaced. If that's lit up, don't worry about it, go ahead and use the oscillator. Oscillator overheated. You don't want to see that. That means that something happened to that cooling gas. If you overheat your piston, overheat your oscillator part in here, it's about a $10,000 repair. Don't do that, okay? And then oscillator stop just means it's stopped. It means probably this pressure went below 7 centimeters or you burn out your piston.
What would you do if it's overheated?
So, first thing I would do is make sure I have my cooling gas connected up right. If I have that, you should be okay. The 3100A is approved for anybody. You could use it on an adult. However, after about 40 to 50 kilograms of body weight, it's not powerful enough to ventilate them. So if I had like a 50 kilogram person on this, I might start overheating my piston. And I've had hospitals that actually have done that, and they've put like fans blowing on this. You're not going to see that here. Okay? These alarms here, if my mean air pressure goes above 50 centimeters, that's going to go off. If something happened, just completely screwed things up. Here's the one you're going to see almost all the time. Where's my alarm silence button? It's 45 seconds. I don't know why it's 45 seconds, but it is. I've taken my baby off. What has happened to their lungs? De-recruited, right. I'm doing something to my baby, okay? I put my baby back on. If I do this on the servo, put my baby back on, what does the servo do? Starts right back up, right? How come this didn't? Because it lost all of its pressure. So how do I repressurize this? Press and hold that. There you go. And now you can let it go.
So once I hear it,
when I do this, this light lights up. There's the line over there. Reconnect your baby. Press and hold, both starts. Okay. You want to, remember I said you should treat babies on the oscillator just like babies on conventional ventilation. The only thing that we tell you about the oscillator is you want to minimize the number of disconnects that you have. Work with the nursing. If they're going to take the baby off to weigh them, they're going to take the baby off to do something, you got to put the new inline suction catheter in or whatever. Do it all together so that you can have one disconnect as opposed to 3 or 4 disconnects. Now, you want to listen to heart sounds or to bowel sounds. I can stop my piston, and I usually won't de-recruit. I did on this one, but I usually don't de-recruit. My piston is stopped, but I'm maintaining my recruitment. Start my piston back up, and you'll be good to go. Okay. Piston centering knob. I want to adjust the piston so that it stays in the middle of my screen there, and it will drift every once in a while. And the reason I want to do that is I don't want it to be bumping up against the metal stops inside. So check your piston centering knob, and then readjust your mean air pressure accordingly. Okay. Good? Couple last things. Condensation. Condensation in the oscillator circuit is a nightmare. It's going to be bad. I wish I could tell you it won't be, it will be. Couple hints to do, make sure that you've protected your temperature probe from any kind of overhead heating. I don't want it inside my isolate. I don't want it to be heated by them. The circuit can be bent in any position you want. I like to bring it in from the head of my baby's isolate. So basically what I would do is I would have my oscillator sort of the head of my baby like that, but I would be turning this so I could see it from the foot of the baby on my baby's bed. I want my Y to be higher than my mushroom valves back here, my Mickey Mouse ears back here. And if I can, I want my expiratory side to be down so that any condensation will go back down to my water trap. If you want to empty your water trap, okay, do not empty it all the way. Don't open this up and let the water drain out, because look what happened to my mean air pressure. It goes down. I'm going to de-recruit some lung, and you may forget to put it back up. Just keep the water level in your water trap steady. I just use the little clips here and use that as a point to be at. All right. There's a little hole in the top here. You may feel some flow coming out. That's fine. Just make sure this cap is on tight. And then when you stop everything, if you turn the oscillator off, that's going to alarm. Just hit that and you're done. One last thing we didn't talk about. I'm sorry, I forgot about this. Inevitably, it's going to happen to you. Baby's been on the oscillator for 2 to 3 days, and they've done really well on the oscillator. You come in, and all of a sudden they're doing poorly again. They just look like crap. Okay, they look as sick as they were when you first put them on. The natural inclination is, oh my God, let's play with this. Let's bump. Let's be aggressive. Before you do anything, get a chest X-ray, and I can almost guarantee you what's happened to the baby is their diaphragms are flattened. As the baby matures, and after about 2 or 3 days, babies start making their own surfactant. So their lungs become more compliant. A more compliant lung takes more volume to achieve the same mean air pressure. And what has probably happened is your baby's lungs have gotten so big, they've collapsed the capillary beds. Okay? So when your baby got first put on the oscillator, when your baby first was born, they have closed alveoli and an open capillary bed. You put them on the oscillator, and you opened up the alveoli, and they sort of stayed there. But as this got more stretchy, it needed more volume to close off your capillary bed. This looks the same as this, but it's treated very differently. Get a chest X-ray. If you see flattened diaphragms, if you see widespread ribs, if you hear a nurse or physician say, ooh, baby's liver is really palpable today, all good indications that you're over-distending your baby. You've got to be strong because you're going to be basically saying, I need to withdraw my PEEP even though my baby looks crappy. But you're going to slowly turn that mean air pressure down, and you're going to hit a point where your capillaries open back up, and bang, your pulse ox is going to go right back up. So if you have a baby who's doing well, and then for no good reason does poorly, before you panic and say, oh my God, let's make changes, get a chest X-ray, and I almost guarantee you're going to see flattened diaphragms, move back your PEEP, and you're good to go. One last thing. Remember I said you're not going to probably change this frequency too often? You may see that flattened diaphragms with a dirty lung field. Not a clear lung field, but a dirty lung field. That indicates air trapping. To fix air trapping, turn your frequency down. Yes, but Tom, that's going to give my baby a bigger tidal bone. Yes, it will, but it gives them more time to exhale. So you may come across some physicians who, even with the smallest kids, are starting their frequencies at 12 now. I have no problem with that because they're trying to hold off, they're trying to prevent any kind of air trapping. I think that may not be a bad idea. Okay, so if you see flattened diaphragms but a dirty lung field, that's in the paper too.
Okay.
Everything I just talked to you about is in there. Trust me. Air trapping, turn your frequency down. As bad as you thought it was going to be, or simpler than you thought it was going to be?
Simple.
Simpler. It's 4 settings. It's not. Don't be intimidated. I know it's a big beige refrigerator that looks like it should be, should be really, really complicated. It's not. Make those little labels. Get Danielle to make some labels for you. Slap them on there. Remind yourself what to do. Use that. Refer to that resource manual that you have in there. There's a couple of good videos that will help you get this set up again. The strategies. I don't have a video for the strategy, but we do have guides for the strategies, and we just went over it.
We only do it whatever they say.